is that of course it is present amongst different diagnoses, and it is a core symptom for major depression. So to make the diagnosis of MDD, we have to have a depressive mood and or anhedonia. So it holds a very special part in depression. And within depression, actually, it was shown that the greater the anhedonia, the more circadian rhythms are disturbed, which is a kind of an indirect way of thinking that if you could act somehow on the circadian rhythms, you could have a beneficial impact on anhedonia, and that's what Dr. Kennedy has actually shown us. But anhedonia is also one of the negative symptoms of schizophrenia, and it's been linked, of course, to decreased dopamine levels, especially in the frontal cortex. Mirtazapine is known as an antidepressant, but there are several double-blind studies where mirtazapine was added to the ongoing treatment with antipsychotics in schizophrenia, and it was shown to have a benefit on the negative symptoms, and that's probably because of its capacity to potently block the 5-HT2C receptors, and when you do that, you really increase dopamine in the frontal cortex. And then the phenomenon that we always see in daily practice is that people with schizophrenia, almost all of them smoke, and so they absorb nicotine, which could act on nicotinic receptors and actually increases dopamine release. So this may be perceived as a way to maybe treat their anhedonia produced by the antipsychotic. So here's a diagram of the dopamine systems with an S, actually. Oops. And so the cell bodies of the cell body of the dopamine neurons are in the mesencephalon here. They're at the same level in the brainstem, and so the substantia nigra neurons are more located laterally, and the ventral tegmental area are at the same level, but more medially. And of course, the ventral tegmental area dopamine neurons project mainly to the limbic system. So here are these neurons, and they would project to, for example, the nucleus accumbens, but also to the frontal cortex. So that's the mesocortical system. And then if we look more at the synaptic level, so we have, of course, the dopamine transporter here, and that's where cocaine, for example, and amphetamine can act, so as to block that transporter to increase dopamine in the synapse. But we at least had at one point a norepinephrine dopamine reuptake inhibitor on the market in Canada in the mid-80s, Americal or Nomifancine. It was removed from the market, not because it was bad on dopamine, but because it produced some aplastic anemia. And I see Dr. Moguin here nodding, and he was telling me that he had quite a bit of good experience with it in his patients. Bupropion, I put a question mark here, but because I don't believe it's acting as a reuptake inhibitor, but more as a releaser, and there's plenty of evidence for that nowadays. I'll be talking to you about pramipixole, or Mirapex, which is a direct D2 agonist, in the next few slides. So what about anhedonia and the dopamine? So the presumed